misconception about what addiction is and the difference between addiction and dependence, physical dependence. So with opioids, you could get them, you know, for a surgery that you had, for example, right? And so you're in pain and you're taking those pills every day for, you know, 7 to 10 days, right? Hypothetically. So if you do that, your body starts to develop a dependence on those drugs to the point where if you're taking them regularly for that amount of time, when you stop taking them, you can go through some kind of withdrawals from them.
Yeah.
So that, though, is not the same as being addicted to the drugs. Addiction is defined by the psychological behaviors that surround the drug use. So, you know, increasing your use, trying to stop but not being able to, neglecting other kinds of responsibilities that you have in pursuit of finding those drugs and using them are all things that characterize addiction. So I think that it's just important to make sure that we differentiate between those two issues. And you know, physical dependence is part of addiction also, but it's, you know, by itself is not the same as addiction. So I think that's kind of just one, especially when we're talking about prescription drugs. I think that often gets lost. And Bill might have something.
Yeah.
No, I think that's true. I think with respect to the recent, you know, the last year or so, with the spike in opioid deaths, that many people think that's heroin or simply the drugs. But as Dr. Harris has shown, the fentanyl, you know, now I think enough people have heard about fentanyl to know that it's a crucial contributor. But opioids are not all alike. There's fentanyl can kill you quickly. It's also interestingly, it was interesting for me to know. I know it's used for breakthrough cancer pain. But we're seeing it in the news recently because it's been used to kill the pain of intubating people being put on ventilators for the COVID-19.
Okay.
And you think, well, so there's another use for this, but it also tells you how tough that intubation is on people. It's not just sort of like, you know, putting something down your throat in an endoscopy. It's really serious business. But anyway, that was.
I would just add one other misconception that I think is important, because Bill, you mentioned the fentanyl. I think especially when you talk about overdose deaths, we often, again, we talk about the opioid epidemic and opioid overdoses. But most overdose deaths, I think like 2/3 of overdose deaths involve at least 2 drugs. So
okay, that's
yeah, and sometimes when they talk about those 2 drugs, sometimes it is 2 opioids. So sometimes it'll be like heroin and fentanyl, for example. But like to Bill's point about how not all opioids are the same, if you look at prescription opioids like Vicodin, which is like one of the lower strength opioids, something like 80% of overdoses with Vicodin include at least one other drug. And that doesn't even include alcohol, right? So I just think that is something to keep in mind often, is that when we talk about overdoses, fentanyl is certainly the most risky drug, but one of the large risk factors that we see is the polysubstance use, the combination of drugs. So, you know, just an opioid, a benzo, and alcohol is kind of like a very deadly cocktail, right, in terms of causing overdoses. And so I think that's another thing that's just important to make people aware of. And, you know, we don't really have the data on how often alcohol is involved in these deaths, because they don't really track that. They just track the drugs. But yes, so that would just be another thing that I would add.
Got it. So mainly it's about, first, it's for opiate, the addiction and also like physical dependence is a different thing. It's kind of like developing stages. And the second thing is like opiate has a lot of uses, and also a surprising fact that like almost 2/3 of people use 2 drugs like 2 opioids at the same time.
Yeah, well, yeah, or not necessarily just 2 opioids, just 2 of anything. So like it could be that somebody, you know, took like a benzodiazepam, which is like Xanax or Valium, like that with an opioid, or it could be cocaine and opioids, or it could be opioids and meth. I mean, there's, you know, people can mix things anyway they want. So when it comes to overdoses, though, most of those do involve some kind of combination of drugs.
Got it. Thanks. So I guess we can move on to the next question. So what led you to keep researching in the like opioid crisis or the drug policy? Like, do you think currently the government is paying enough attention to it, or do you think like the public should pay more attention to it?
It's what we do. We, our purpose is to find out what's going on and what are reasonable policies. And so when the opioid crisis is in the news all of the time, we have to see what we can say about that, what we come to understand it, and how we can comment on it responsibly, and perhaps offer concrete policy recommendations both to the Texas legislature and to the federal government. And it's just like now, we've been working on some other things, but there's no getting around talking about COVID-19. That we've got to see how is this related to other aspects, including we're being asked now to do a webinar soon about COVID, about the coronavirus and the opioid crisis together. So things pop up. They're not always we don't always go say, hey, there's something else that would be interesting to study. When it comes and says, pow, we've got people ask us, what do you think about that? Well, I was just going to start thinking about that.
Right.
Yeah, it just goes. To us. It's one of the exciting things about what we do. And I taught sociology at Rice for 38 years, and I always thought that was why it was so much fun. Is there's a sociology of everything. That there's no reason for a sociologist ever to get bored.
Got it.
Yeah, and I think at the end there you had asked a question about whether or not we think that the government is paying enough attention to it, and I think certainly now, as Bill said, I mean the COVID-19 stuff is just taken over everything. So I think right now I think that all other issues are sort of put on a back burner. Prior to that, though, sort of the government response, I think that certainly there has been a lot of lip service paid to the opioid epidemic, and I think we saw some pretty large federal aid packages come out with funding for states to respond. I think that it wasn't done as well as it could have been, in the sense that the money that they gave was very targeted specifically towards opioid spending. And as I mentioned, there's more than, it's sort of treating a drug versus treating the underlying problem, which is just general drug use, and especially the polysubstance use. So I think that, there's been limitations in it. And I also think that there's still, in terms of effective treatments, I think that we are still not, being as evidence-based as we could in terms of what kinds of treatments we are providing for people.
Yeah. Got it. So it's like people are not paying attention to like how to treat specifically to different kind of drugs, to different kind of patients.
Well, what I mean is that, so for example, in other areas of medicine, right, we expect evidence-based medicine, right? We expect, we know this thing works, and we expect, providers to provide the care that has evidence behind it. But with drug treatment, it's not often like that, right? So with opioids, there's medication-assisted treatment. You may have came across that in your research, like methadone and buprenorphine, for example, right? So that is an evidence-based medicine and an evidence-based treatment modality for people. But there aren't specific requirements that it's offered by treatment providers. So, and also, there's we still have all these kind of very expensive residential treatment places, like the Ford Clinic and Hazelden, and there's others, Malibu Recovery. There's these and they cost thousands and thousands of dollars a month, and they say, 30 days and you recover and everything, and there's really no evidence behind that approach at all. And so, but things like that it's a very unregulated area, drug treatment is, right? So I just think that is kind of one of the things that we continue to have a problem with.
Got it. Yeah, I've seen something like that before. I watched a documentary about like treating different kind of thing. It turns out like most of this kind of like help groups, they're just like they don't base on like a kind of like a rigorous discipline or something. It's just like someone think that this might help and then just they form a group and like let everybody in. But like most of the cases, it turns out to be like not that effective to treat opioid users, right?
Right. Yeah.
Got it. Yeah, so I guess a third question that we have is like, is there any advice you might give to the public about opioid usage? For example, about like people who are going to take painkillers or doctors who are about to like prescribe opioids. What do you think like they should care or think about before they really do the action?
Well, so I think one thing for people to understand is specifically what the risks are with overdosing. And to that, I think it's important to warn people of particular drug combinations.
Yeah.
So again, like if you're prescribed an opioid and you're going to take this opioid for pain, like be very careful about taking other things. Be very careful about also drinking, or if you,
that's really
and I think I think now, and it depends, but I think sometimes there are pharmacies will kind of look and say like, oh, well, you have this prescription for this opioid, but you also have this prescription for this, benzo, like Xanax or Valium. And, they'll try to warn people about it, but that's not always the case. I have a friend that got, she was getting some dental work and the doctor gave her a prescription for both. Like, yeah. So I think education about like what risks like of certain drug combinations, I think is really important for people.
I think when people are being given these drugs, that doctors or friends should also say, it's legitimate. My wife has had 2 knee replacements. That hurts, and you need that in order to, if the pain takes over, then you're not likely to do the therapy and things of that sort. But it's important also to let people know this is a legitimate use. You don't want to kick the pain door open if you don't have to. However, when it starts to subside, these are not good to stay on any longer than it's necessary. And that for one's own use to say, I think I'm going to give it a try without this, and if it works, stop.
Yeah, and to that point, I think the other thing I think that's important for people to understand is about having to titrate their dose down, right? So that's something that, like, if you're taking them, like, because I mentioned the physical dependence thing, right? So if you are taking them for 7 to 10 days and then you just stop one day, you're not going to feel very good. I mean, you're not going to have, you might not need to go to the hospital, but you might feel, it might be pretty unpleasant. And then that might make you want to take another one. And that goes to the physical dependence thing. And I think sometimes doctors don't always talk about the titrating of the dose. You just get, especially when it's for acute pain, surgical pain, it's like take one as needed. But I think people need to understand that if they've taken them for several days, that, maybe they need to like just take half a pill, for example. There are much more like specific recommendations in terms of titrating doses down when you've been on them for a long time. But I just think that general idea is important to make people aware of.
Got it.
And
go ahead.
So you perhaps have read, there are a number of magazine articles and several books written about the real harm that was done by big pharma, in particular pharma, PHARM, pharmaceuticals. The doctors have been urged by the company, sometimes with rewards and the different kinds of prizes, to push this drug, telling them often this is not addictive because it's time release and things like that. That a lot of things are done, I think, purposely by the pharmaceutical companies to push to push the drugs, and perhaps naively by the doctors, but also people come to doctors and they have these pains, and the pains can be real or they can be imagined. You say, I'm real busy, take these. That there can be a lack of conscientiousness sometimes about what is what is prescribed.
Okay, got it. So it's like sometimes it's the pharmaceuticals for, that they are not paying enough attention to like people's awareness of this, and also like sometimes doctors are not like being responsible enough to like prescribe the right drug. Is that?
You can go to New Yorker and read some articles about that, long, really well-researched articles. It's not the only place.
Okay.
I read a really interesting book called Dreamland. And it's easy to remember. It's by Sam Quinones, but remember Dreamland. And it talks about not only how the heroin epidemic was spread in recent decades, but also it moves back and forth between the heroin business, but also about how the pharma company pushed this, systematically pushed it. So it's a good, interesting read, but it's quicker to go to something like New Yorker and put in pharma.
Yeah, sure. So I guess we can move on to our next question, which is, do you think that opiate issue is a social problem that is not paid enough attention to by social media? I mean, like you have just mentioned, like the federal government are sending some aid, like at least they're doing something, but what about the social media? Do you think that social media has exposed enough stories and like things behind this opiate uses? I know like right now COVID just takes everything, but what about before COVID? Do a lot of social media pay enough attention to it? Is there something they should work on? What do you think?
Do you mean like the companies themselves, like Facebook and Twitter? Like, do you mean like the companies themselves, or the conversations that are happening on social media?
I guess the conversations that are happening on social media.
I think it depends. Like, if you go on Twitter, if you follow people that talk about drug stuff on Twitter, they talk about it all the time. So I think it kind of depends on the like what little bubble that you're in, right? So I follow, like I'm on Twitter and I follow a lot of people that do drug research and do work in treatment and harm reduction, that kind of stuff. And I mean, this is all that they talk about. But if you don't follow those people, if you're not in like already knowing about that conversation and knowing to seek it out, then I don't know that you would really be that aware of it.
Okay.
That's exactly. I was just thinking it depends on which silo you live in.
Yeah, right. Yeah, I mean, I think
bubble's just fine too.
Yeah, I think that there's, I think kind of like one of the things sort of underlying your question is the whole idea about sort of like these like public awareness campaigns and that kind of thing. And there's varying research about whether or not public awareness campaigns actually work, like how much they prevent things and that kind of thing. But I do think that I think public awareness campaigns can be good for a couple things. I don't really think that they are that good at getting people not to use drugs, but they can be good at providing information, and they can be good at reducing stigma, right?
Okay.
So there was a billboard that was created in I think it was in South Dakota, that caused like a big stir, and it was about meth, because meth is a big issue in South Dakota. But it was this billboard that had like pictures of people that was like, I think just the message said like, I use meth, right? And it was, people kind of made fun of it. They criticized it for a lot of things, but I actually thought that it was a pretty good way of trying to destigmatize meth use in a way that would, allow people to feel like they could seek treatment for it, and not feel like their issues were neglected. If I remember correctly, they paid an ad agency $500,000 to come up with that, which was a whole lot of money. But I do think, so I think though that the main thing that we could be doing, on social media and just in terms of awareness is, again, like the education about, what, again, like just how, if you are going to use drugs, how to use them safely, right? In any context, whether you're using it for pain or recreationally. I mean, because people are going to do that, right? We're just not gonna be able to stop everybody from doing that. So I think providing information about how to reduce the harms around drug use, and then I also think messages about trying to destigmatize drug use itself, I think are what we could be doing in terms of public education and on social media.
Got it.
It doesn't mean we're saying, hey, this is great for you. So there should be stigma attached, but that you want to say, you said, Katie mentioned, I remember going to a Drug Policy Alliance meeting, and very attractive young woman stood up and says, "I use meth." You think, really? Wow. Then that's remind. They may have gotten that company may have gotten the idea from her.
Yeah.
But to destigmatize it, so that people could say, okay, this is something I need to know more about if I'm going to do it. I need also not to be so ashamed of myself that I can't seek the help that I might need. And if you've looked at our website, you know that we say openly that we're as distinct from prohibition, we are in harm reduction, recognizing that you can't stop all of this, even if you wanted to stop all of it.
Mm-hmm.
But that there are ways of, that, for example, talking about medical assisted treatment or heroin assisted treatment. If you can use, as is done in some countries, if you can use heroin to help people deal with their heroin abuse or use, then that's better than saying there's only one way to stop this, and this is to make you stop and punish you. Those are two things, but those are not related. So that you have to deal here with, there are situations that we cannot fully control, but we can perhaps reduce the harms.
Got it. So more public education and also like more kind of gentle ways of approaching this question instead of like just violently like, oh no, you can't do this anymore, you have to quit it. That's different. Okay. Yeah, so I guess we can move on to the last question. So since our group is more likely sociology collaboration group, and we are trying to do something actually like maybe influencing Rice or like in Harris County in general. So what are some things that you think like ourselves, like students or like the general public or like students at Rice could do? I know there's opiate discussion maybe last semester that was held at Rice, and I find that pretty useful. Do you think like we should have more of this kind of like opiate discussion stuff, or do you think there's any other activities that might be really useful in like public education or stuff like that?
Well, I generally think that light is better than heat for these things. That talking about it and trying to deal with misconceptions.
Okay.
And say now, I have talked. For example, I've spoken to lunchtime groups at a couple of colleges.
Okay.
And once I remember we were talking about marijuana, and I was trying to say, okay, this is what we can say with some confidence. There are problems with this. We think that it should not be a crime, but that's not the same thing as saying this may not be at all good for your academic your academic career, and a number of just being realistic. I think with respect to opioids in particular, I don't know how many there. There have been very few over the last 10 years, and I'm in my 52nd year at Rice, so it's still a tiny number over that whole period. But occasionally somebody dies of an opioid, of a drug overdose. Sometimes it's probably mixtures of opioids, and at least a time or two, I've been told it's just heroin. That it would be good to have discussions that say this can happen. This can happen at Rice. It's rare, but you need to know the facts of this, and that talking about it is that's what we do for a living. So we're talking and writing. We're inclined to think that's a very useful
I ask this every time that I talk to students about drugs, but what is your impression of drug use on Rice campus?
I know that definitely exists. Like it's not like Rice is like a place without or the like opiate and drugs. I definitely know that exists. It's just like I hope those who like have this kind of like opiate uses, like they're doing that for a legitimate usage, not for like for overdose or something like that. It's just like if they feel pain, they can use painkillers, but like try to use it in a legitimate way, not to like endanger themselves and also like to harm others. Or like one thing I really noticed is like there seem to be some kind of like opioid like exchange uses and stuff like that. And I was just hoping like maybe in orientation week, like they can touch more on this kind of issue and like topic about like, okay, this thing exists at Rice, but we suggest you that like maybe you shouldn't like take it or something like that.
Yeah, go ahead.
Well, I was just going to ask you, are you, have you know about the substance use task force that they have at Rice? The woman who runs it, her name is Agnes Ho. She's in the, I guess like the student resource department. I don't know exactly what the like, but anyway, there, yeah. So if you look it up though, there's a substance use task force at Rice. And I think that they're the ones that organized, I don't know if it was the same meeting that you're talking about, but there was one, I remember it was last semester, the one before that about opioids campus. But they're kind of working to try to get awareness about certain things at Rice. And I joined that task force right before all this kind of happened. And so now I don't know, you know, everything's, again, it's kind of on hold. But I know, so, you know, like one of the things that they were trying to do is get Narcan on campus, like to students. Narcan is the drug that reverses an opioid overdose. And so one of the things that that group was trying to do was get it on campus. And one of the things that I was thinking, you know, back to Bill's point about the education, the awareness kind of thing, I think it would be good for there to be sort of drug, like a kind of like a drug education thing on campus.
Definitely.
Like a meeting, like meetings that could be had sort of regularly, either like you said, like in the beginning of the semester with orientation, but that teach Rice students just again about using things safely. Like if you're going to use these things, this is how you should do it safely. And I had brought that idea up to the task force, and I think you know, one thing that I was kind of told was that the Rice administration might not necessarily go for that idea of sort of teaching Rice kids how to use drugs. But I mean, the reality is from when I've talked to other Rice students, maybe there's not like a widespread opioid addiction problem on campus, but there is a lot of heavy drinking from what I'm understanding. There's also a lot of, you know, Adderall use, you know, marijuana use. I mean, so there, you know, and alcohol is a drug. And so I think that one thing that you guys could do is, you know, if you wanted some kind of drug education thing, and we could, you know, it could be discussed mainly about alcohol and healthy drinking limits, right? But it could also include information about, you know, other drug use and just avoiding certain kinds of risks from that use. I think, you know, if the students asked for that, you know, from the Rice camp of the administration, I think that would, you know, give them some reason to do it. And I think that it could be really, really helpful for students. But I think, again, I think that's something that the students themselves would have to ask for versus us just being like, hey, we want to, you know, talk about this thing.
Well, I was, my wife and I were masters of Sid Rich, now called magistrates, but of Sid Rich from 76 to 81, when it was all male. And we had, there were only 2 or 3 people who smoked. I mean, smoking is still, I think, very small at Rice, but there were people. I mean, we had one guy who had a brick of cocaine in his room, but he also left and sort of disappeared. He did show up. He was alive, but anyway, we had some things like that, and we had some people who smoked regularly, and some you couldn't tell, and some you could. And I used to ask students who would come in and say, you know, school's kind of bogus, and I may just take out and travel the country. I got to take my guitar and hitchhike. I'd say, how much pot are you smoking? Well, I smoke every day, but I don't think that has anything to do with it. Well, it does. So let's talk about it. But again, I think Katie is right to do something that probably could be done. I'm not even sure the administration understands how important the colleges are. That an individual college could look at, I mean, each of the colleges, but I mean, could look at the thing, what could be done in their college and find people who are interested in that. And I believe you could organize things and people would attend. People would take an interest in that, but it would be better coming from at least for the demand for it coming from within the colleges. And that the college system can be a powerful a resource or a generator
Okay.
of resources.
Got it.
Yeah, no, I completely agree. Yeah.
Got it. Yeah, so it's more like if students have this kind of demand, then like more resources will be allocated to them. It's not like we should advise others to like help students if they already have problems.
Yeah. What college are you in?
I'm from Martell.
Martell. I had my granddaughter, Anna Thomas, was in Martell, but she graduated, I think, 3 years ago. So
Okay, yeah. I'm still a freshman, so maybe not.
I have a freshman's grandson in Duncan, and my daughter is the coordinator at Will Rice. So we take a strong interest in the college system.
Yeah, of course. I think the college system is really useful, especially if you want to like spread some news or like if you want to gather more attention of the something, like especially in opioid. I think it's really a good choice to like just advocate through like maybe college magisters and then like into like college president, and then like they can tell like what the students can do or what students probably could like use as a resource in their own college. Yeah.
Katie and I have talked about having we've written a paper about vaping, and we thought it would be, we could do an op-ed for the Thresher, and we were ready to do that, but then the Thresher, the things went dark. So, but we could do that. The dealing with vaping is not going to go away by with September. That, by the way, is another. Why are you writing about vaping? Because everybody's talking and on the TV about vaping, and so we have to know what we think about this.
Okay.
Interesting process.
Yeah. Hopefully,
it's good to be an academic, particularly in sociology.
Yeah. Yeah, I think that's all the questions I have. So if you guys don't mind, can I post this kind of recorded video to our project, and then like we can let more Rice students know about it?
Yeah.
We'd like to keep everything we do secret. Of course you can. We'd be delighted.
Yeah, it's fine.
Yeah, great. Thank you guys so much, and please stay safe.
Yeah, you too. It was great talking to you.
Enjoyed it.
Yeah, thank you. Bye.
Bye.